Good morning, and thanks for joining us today for Smelling the Smoke, Fighting the Fire, supporting students with co-occurring substance abuse and mental health needs. As we proceed through today's presentation, this title will begin to make a little bit more sense. First off, an introduction. My name is Mitch Barron, and I spend much of my time and energy and effort as the Director of Centerpoint Adolescent Treatment Services. I'm looking at the screen now and seeing that our formatting's a little off, but you can line up the information with the logos. Centerpoint Adolescent Treatment Services, some of you may be familiar with this, and I'll talk a little bit about Centerpoint in just a moment. I have also taught at UVM in the counseling program and currently do field supervision for counselors in training as well as for the social work department. On the prevention side of things, or the early intervention side of things, I'm connected and affiliated with Connecting Youth, which is the youth prevention organization, the substance abuse prevention and youth development organization in the Chittenden South communities, the 5 towns that feed into CVU High School, including Williston, St. George, Shelburne, Charlotte, and Heinsberg. And I'm also on the board of a similar coalition in Burlington, known as the Burlington Partnership for a Healthy Community. Again, just a little bit of Centerpoint's information. Here's some contact information, including our website. And if you're not familiar, I would certainly invite you to take a look at our website and learn a little bit more about what we do. At Centerpoint, we do have a full host, a variety of services and supports for young people, kids and adolescents, and transition-age young adults and families who struggle with the broad range of social, emotional, mental health, special education, substance abuse, kinds of issues that impact their daily life and success. Located in the Burlington area, South Burlington and Winooski, but really serving young people and families from throughout northwestern Vermont. So again, please feel free to take a look at our website to learn more. But before we proceed with today's training, I have a question. And it's obviously not a question you'll be able to answer on the webinar, but I will say that it is a question that I ask of young people, I ask of parents, I ask of groups of students, of high school and college-age students, really anyone I see. And the question is, why do people get high or do drugs? Drink, smoke pot, snort, trip, take pills, shoot, get drunk, get toasted. So I ask this question often. What you'll see on your screen now are the answers that came from a group of transition-age young people, a group of college students. They took about 15 minutes to put together this list, and there's probably about 125 or 130 answers on this list. If I gave them another 15 minutes, they'd probably come up with another 50 or 100 answers. In another 15 minutes, there would be more answers than that. So we look at this, rebellion and performance enhancement and revenge and self-regulation and to feel attractive and to be productive and to manage pain. And we see 150 answers up here, which can be a little overwhelming. What are we going to do if these are all the reasons that people are drinking or smoking or misusing or abusing drugs and alcohol? The good news that I'll offer is that when we look at this board or when we look at these lists, we can really boil these answers down to a couple things. Most of them, perhaps all of them on the screen, fall into 2 categories. People are misusing or abusing drugs and alcohol to feel good and to stop feeling bad. And in some ways that makes our job a little easier because all we have to do is help people to feel good or to stop feeling bad, and in parentheses you'll see to manage feeling bad. Bad feelings are a natural part of our lives, but it's how we manage them, how we deal with them, how we take care of ourselves. So at Centerpoint or in treatment services, we'll look at helping people to feel good, and we'll look at helping people to stop feeling bad. But of course, that's not the way we'll talk about it when we're trying to use the expensive words or when we are talking to some of our insurance companies or funding sources, but we help people to feel good by helping our students to expand their array of adaptive coping strategies, pro-social skills, and positive experiences that will result in healthy endorphin, serotonin, and dopamine production and lead to improved interpersonal functioning and environmental success. So that sounds good and important, but at the end of the day, that is about feeling good. And similarly, within treatment and support services, we look to ameliorate the co-occurring mood and anxiety and personality and trauma-based social, emotional and mental health disorders, and to immunize the contributing psychosocial and environmental stressors that compromise a person's well-being and environmental functioning. So again, big words and important issues within those phrases, but at the beginning and end of it, we're helping people to feel good and to stop or manage their bad feelings. So if that's what we're doing, another question. What's the big deal? What is the big deal with misuse or abuse of drugs or alcohol? Well, it's certainly a legal issue and a political issue, a family issue, a health issue, a wellness issue. We know that the legalities and the politics are changing as we, really as we're talking today. This legislative session in Vermont, we're seeing some really interesting things. We know that one of the drugs that is seeing the greatest misuse and abuse these days is actually a legal drug. It's not even an illicit drug. But the opiate medications, oxycodone, OxyContin, those kinds of things. There are plenty of legally prescribed, misused drugs that are impacting a person's health, impacting a person's wellness, impacting a person's family functioning. So it's a big deal. At Centerpoint, we'll often get the questions, how do I know if my child is using drugs or alcohol? In fact, sometimes the questions will begin like this. I think we need to get a drug test. We need to do a screening. And we'll certainly be able to offer that service, but be curious about the question. And what we'll hear are things like, my students got different friends now, and they're sort of, flatter and not engaged in the family as much, and their grades are failing at school. Okay, those are all indicators, and we'll listen to that. And then we'll hear, and I found a bag of weed in his underwear drawer. I found a bong in his closet. Truth of the matter is we learn all kinds of things without the need for drug testing. We see and we look and we listen, and sometimes we have to ask hard questions to get the right answers. And we don't need a drug test if there's a bag of pot in your child's dresser drawer, pretty good indication that he or she is getting high. But sometimes being able to listen and look and to see with open eyes is quite a hard thing, and we'll talk about strategies for that today. Before we go further, I do want to talk a little bit about drugs. Today's training, today's conversation is not specifically about drugs. It's not specifically about all the classes and categories. You don't need to know everything about everything to be able to do that well. Additionally, it's not really going to be about substance abuse treatment or integrated treatment. There will be a foundation of that, but what I'm hoping that comes out of today are some functional and practical skills, style, strategies that listeners to this webinar will be able to bring into your life and into your practice, whatever your situation is, if you're a counselor, if you're an educator, or if you're a parent. All these things will apply. But first, a little bit about drugs. Classes and categories. We do see the drugs of misuse and abuse fall into a variety of different categories. Some of these drugs can be categorized differently, particularly some of the synthetics are interpreted or understood or looked at chemically a little bit different. But these are the things that we're oftentimes seeing misused or abused. Certainly, the opiates are of great concern in our Vermont communities these days. Initially, we were having a surge of heroin some years ago, and then more recently, the opiate pain medication and pain relief pills, oxycodone, OxyContin, and as you might be reading very much in today's paper, yesterday's paper, heroin is on an upsurge. So there's certainly some high-profile drugs, but I would just acknowledge that in the most recent National Survey of Drug Use and Health, which is really a gold standard survey across the country, if you've not already heard this information, Vermont has been ranked #1 in use of marijuana for people under the age of 18. Vermont has ranked #1 for use of alcohol by people under the age of 18. Vermont has ranked #1 for use of marijuana for people aged 18 to 25, and #1 for binge drinking for the 18 to 25-year-old population. So we absolutely need to be concerned about opiates, and we need to be concerned about meth, and we need to be concerned about misuse of a whole host of drugs. And at the beginning and the end of it, alcohol and marijuana still remain a significant concern for us. I might offer that it would be hard to stay in front of all of the information and all of the changing information regarding drugs of abuse. There are a few resources that can be helpful. These books or manuals that you'll see on your screen now, the one on the right side of your screen, Uppers, Downers, and All-Arounders, is really a great text. I've used that in classes and in courses, and fairly pricey, so unless you're really interested in the academics and perhaps in the professional end of this work, that's probably less recommended. Street drugs, the pamphlet or the manual on the left side of the screen, which I believe is still free. There may be a small charge for it now, but I believe it's still free at streetdrugs.org. Glossy pictures and good descriptions of information. Personally, I'll use that, but I will not have that lying around because some of the way it's laid out, some of the photographs, it almost looks like an ordering catalog, and frankly, sometimes that can be too much information. But if you just wanted to learn a little bit more, the book in the middle, Buzz, the straight facts about the most used and abused drugs from alcohol to ecstasy, is a great Amazon, Barnes & Noble kind of book that can give you some foundational information. Not that you need to be experts on substances of abuse, but when you're working with young people or when you're parenting young people, knowing a little bit helps you be involved in the questions and the conversations a little bit more. Similarly, there's a couple websites that I'll direct you to. Again, if you're working with young people, there's a great chance that they're familiar with Arrowwood, arrowwood.com. Arrowwood presents itself as balanced information, and to a great degree there is good information on the Arrowwood website. In fact, there's so much information that while they do acknowledge risks connected to substance use, sometimes they get buried in the acknowledgments of benefits of substance use or benefits of particular drugs. Most schools have the website Arrowwood blocked from access within school sites because they interpret it as a pro-drug website. I certainly would not have this sitting on my browser in the office or in your office or your living room at home, but parents or providers or supporters of young people may want to take a look at this because there's a good chance that that your young people are familiar with this website. And again, there is helpful information in here, so you could dig around a little bit. As an alternative, when a young person may speak to me about Arrowwood, I'm going to have the Fix up on my browser. And the Fix is a little bit more of a, even as you can see from the graphic on the screen, is a hip, fast, well-designed website, but it does support, it supports living a drug-free life. It's hard to read the tagline underneath the words The Fix, but it says addiction and recovery straight up. So there's a little bit of a pop culture element to it, but it just presents an alternate view for those young people who are coming in with information to demonstrate to you or prove to you how there are no concerns, no risks, or no problems with substance use. So Arrowwood for you to check out, Fix for you to share with others. But if we come to an awareness through good screening, assessment, or just good eyes and ears that the young people that we know or may be working with are struggling with substances, a third question that I'll raise is, what does it mean? And again, as I mentioned earlier, the focus of our conversation today is going to be functional significance. How do we understand it and what do we do? So let's first talk about severity of substance use in the lives of our students. Diagnostically, at least through the most recent or the immediately past recent Diagnostic and Statistical Manual, these are typically the diagnoses that we're seeing. We're seeing substance abuse, we're seeing substance dependence, opiate dependence or alcohol abuse. We're seeing a related disorder, NOS, which is simply a catch-all to say there are concerns, but they might not meet all the diagnostic criteria of a particular abuse or dependence diagnosis. We're seeing substance intoxication as a diagnosis, and substance withdrawal, opiate withdrawal as an example. In substance-induced disorders, certainly at the hospital and particularly around the transition age population, oftentimes first breaks of schizophrenia or more major mental health disorder can be tied to drug use. So it's referred to as substance induction. But I'm going to suggest that we not, for the moment, get caught up in diagnostics, and that we, as I said, think about functional significance. And with that, I'll offer this. We see people, particularly young people and transition-age young adults, used for a variety of reasons. And the first reason I'll talk about is recreational and social use. And I want to highlight that oftentimes we'll hear the phrase experimental use. Oftentimes when somebody uses that word to me, it's not uncommon that they put quotes around it or do the rabbit ears with their fingers to say things like he's just experimenting or she's just experimenting. Historically, I would say that never occurs. A little bit later in our conversation, I'll talk about how that does occur. But most often when people are talking about experimenting, they're actually talking about recreational and social use. People are using to feel good or to stop feeling bad with friends and with peers and in social settings. Good, bad, or otherwise, I'm not passing that kind of judgment. I'm just acknowledging that this type of substance use or misuse or abuse of drugs and alcohol, when we understand it from a recreational or social perspective, that guides us in what to do. And at Centerpoint, or in a clinical setting, we will see some of that find its way into our practice setting, if for no other reason than it's often connected to illegal behavior or policy violation behavior. The next category, and certainly a larger category of what we'll see, we refer to as symptomatic use. And this is where smelling the smoke and fighting the fire comes in. Symptomatic use we define as substance use that is a result of, or as an indicator of, or as a concern with more significant underlying issues. I'll oftentimes say that in our local high schools, they all have clear policies regarding substance use, and none of them have clear policies regarding depression or anxiety or an unidentified learning disability or stress or trauma or family challenges. So those things may be going on, but they're not always as easily noticed, and they're certainly not as clear a response. So symptomatic substance use might be when somebody walks in our front door because of a drug or alcohol misuse issue. But really what's going on are a whole host of issues underneath. Now, sticking with the smoke and fire metaphor, we are addressing both. However, the fire are the issues underneath. We don't ignore the smoke, we don't ignore the symptoms. To stick with the metaphor, in fires, what kills most people are the smoke, are the symptoms. So we're attending to the symptomatic issues, but we're making sure to primarily address the underlying social, emotional, and mental health concerns. The next category in this model would be understood as primary problematic. I also just want to make a note that this is not linear, this is not developmental. You don't necessarily start out at one and move to the others. It's not a progression. It's just a way of organizing the reasons that people are using. Primary problematic, when we see these issues, it means that our significant attention is on the substance use. Primary problematic substance use will still have other co-occurring issues underneath, but either based on the particular substance of use, like a substance that has a greater potential for chemical dependency and addiction, or whether it's the duration of use or frequency of use or age of initial onset, a person that we might see at age 16 who has started abusing drugs at age 7 or at age 8 or at age 9 and has been consistently using throughout. We've got some other problems that are more primary. The last category in this model would be looking at the category of addiction and dependence. Sometimes phrases that get commingled or replaced for one another, but just for the sake of this conversation and with some brevity, chemical dependence is really neurophysiology, it's neurochemistry. Chemical dependence, if you are properly prescribed and properly taking an opiate pain reliever for a torn ACL or a back problem, and you're on that opiate pain reliever for a period of time, you're most likely going to develop a chemical dependency. Opiates hijack the neuroreceptors in the brain. And working with your doctor as you taper off that medication, you're most likely going to experience some symptoms of withdrawal. Maybe it will just be lethargy or tiredness or headaches. For some who are more impacted, it could be flu-like symptoms. Chemical dependency is neurochemistry related to the drug. Addiction, an easy way to describe that would be to say when a person organizes their life around the drug, or truth be told around any behavior, but sticking with this conversation around the drug. This is the things that we commonly hear: abandoning friends, abandoning social connections, abandoning pro-social or successful experiences. Sometimes you'll hear sort of the term drug-seeking behavior when it's all about getting high. And that's a way in which we describe addiction. And again, in conversations with young people, that's how we can do a whole end run around a debate of whether marijuana is addictive or not. Whether marijuana creates chemical dependency, the research is sort of in its formative stages, and there are different positions and points on that. But I'd say that is marijuana addictive? If a young person has reorganized their life around that drug, then that becomes the definition of addiction. Now, there's a little peek at this triangle that it was never here previously. I've included in the past few years, and I've reinserted the idea of experimental use. And again, this has been a little bit of a boon of the internet. It's been connected to some other things we see. But as I acknowledged before, experimental use is oftentimes used to describe recreational and social use. We are now seeing things that look more like experiments. We are seeing, and again, it's more with the transition age population, more connected to a couple of the colleges that we work with through Centerpoint. But where we will see young people who look at the chemical formulation and chemical makeup of illicit drugs, compare that chemical formulation to drugs that are more easily accessed over the counter or more easily accessed in drugstores, try to figure out how much they need to take of the legal drug to get higher to get the same effect. I used to say it's not an experiment. There are no tests and retests, and nobody's writing journal articles after it, although now it looks like we have some young people who are doing that. Truth be told, that's very concerning. While all of these drug functional significance categories have risks attached, recreational and social use that gets behind the wheel on a Saturday night can be just as fatal as chemical dependence. Experimental use is particularly concerning, and this is things that have come to us through emergency rooms. These are young people who have been identified with other mental health issues induced by their experimentation. So we just keep an eye out for that as well. But the functional significance frame offers us an understanding of why people are using, which, as I said earlier, will then guide us to what to do about it. I've dropped the phrase co-occurring disorders a few times now, and I just want to acknowledge that substance use often occurs co-occurring with, as a result of, or as a cause of other concerns. It's rare that we are seeing a young person who is misusing or abusing drugs or alcohol and there's not something else going on. Okay, that something else going on may be a diagnosable condition, it may be a condition in need of treatment, or it may just be the complications of life stressors that challenge a person to be able to feel good or to stop feeling bad in healthy ways. But co-occurring disorders really acknowledges that there are oftentimes multiple things going on at the same time. Similarly, when we think about the severity of mental illness, mental health issues, or emotional disturbance in the lives of our students, there are common diagnostic categories or areas that we are thinking about, and you can read those on your screen. But in a very parallel way to the substance use issues, we look at functional significance. And so, more commonly, regardless of diagnosis, we're seeing issues that present as defensiveness or opposition, behavioral noncompliance, distractibility or attentional issues, verbal or physical aggression, passivity or avoidance, emotional outbursts, seemingly irrational thoughts or behaviors. Now, some could look at this list and say, isn't that just the definition of adolescence? And point in order, to some degree it is, and that's an okay thing. Really what we're talking about is gradations here. And why I bring up the idea of functional significance rather than diagnosis, is he or isn't he, does she or doesn't she? We're seeing these things and we're seeing them in gradations. And with a diagnostic perspective, I might say it's less important which is the chicken or which is the egg. Are mental health issues a result of substance use issues? Is substance use a result of mental health issues? From an integrated treatment perspective, from a co-occurring disorders perspective, it really doesn't matter. Good practice says we're going to address everything that presents. So, acknowledging the importance of good assessment and diagnosis, accurate diagnostics do require us to distinguish between different disorders, so discrete disorders is the language used, and between discrete disorders and induced symptoms, okay, and that cause effect. That is important in differential diagnosis. However, when we think about what's important for the work that we're doing, and that might mean in the schools, that might mean in the living room, or that might mean in the clinic at Centerpoint, from a treatment and support perspective, these discrete diagnostics, these cause and symptom relationships may be less important, as intervention strategies that are appropriate for a specific diagnosable condition will likely remain effective for the behavioral presentation, whether it's primary or symptomatic. So what does that mean? That means that if we are working with a person who is diagnosed with a major depressive disorder, there's certain things that we're going to do. One of them might be medication treatment based on psychiatric care and oversight. But there are behavioral approaches, there's relational approaches, there are treatment approaches that we're going to use for that person who is struggling with a major depression. And frankly, if there's a person who may not be struggling with a major depression, but is sad and is flat and is having a hard time in their life and is having a hard time coping with the stressors in their life, we are likely going to be using the same strategies, and we're likely going to be seeing just as positive an effect. And truth of the matter is, if these strategies are not effective, we've just gathered useful information. If we see somebody who's presenting as sad or flat or disengaged or hopeless, and the strategies we're using are not having good effect, it means we've missed something. And again, in our experience, commonly what we've missed is something physical, physiological, or biological. So this leads us to look at an integrated approach. And one of the things that I will always say, and I'll always guide parents or families who are accessing treatment, is that you cannot address a mental health or emotional disturbance without addressing substance abuse, and vice versa. Okay, so which comes first? Which do we have to address first? If they are both sitting in your living room, if they're both sitting in my counseling office, it's not which first, it's both now. So, as I mentioned, I'm not going to be spending a lot of time talking about treatment, but I do just want to give an orientation to how we're approaching integrated treatment for co-occurring substance abuse and mental health issues. And again, another conversation or more information from our website, you can certainly learn more. But in treatment, these are oftentimes the things that we are looking to achieve. And more at the bottom acknowledges that people come in with their own individual goals, needs, and interests, and of course that becomes primary. But we're helping to ameliorate symptoms, attend to that smoke I was talking about. We're helping to people to comply with expectations, whether that is school-based violations or probation or work expectations. But more importantly, in addition to the things that people need to stop, we want to help people start. We want to help people achieve goals, improve their functioning, and become healthier. And the way in which we do this, or the lens, the frames through which we work, look at motivation, skill, and capacity. Now, some who are listening, particularly people who have either been to trainings around motivational enhancement strategies or counselors or educators, may be familiar with different models of change or stages of change or process of change. And I'll offer this one, which is a dynamic and interactive. Motivation, skill, capacity, the interplay between these three. Motivation, sometimes I think about these two questions, why or why bother? These are great questions. Our young people, our kids, our students, our clients ask us these questions. Periodically they sound like this, and periodically they might sound a little bit more coarse. They might sound like, that's stupid, or I don't need that, or you don't know what you're talking about. And we have to hear that, and we have to put in our adolescent earbuds and translate some of their messages into These kinds of questions. Why or why bother? We are asking people to stop using strategies that have worked for them. Getting high works for a lot of people. We may know that the ways in which it doesn't work in the long run far outweigh the ways in which it does work in the short run. But in the moment, people are feeling good, or they're stopping feeling bad by these strategies that they're using. And we're asking people to change their behavior, change their thinking, change their choices. Why or why bother are incredibly valid questions. And they're questions that we better have good answers to. We do a lot of work increasing motivation for change, motivational interviewing strategies, and motivational enhancement therapies and decisional balancing. But this piece of the change process can't be missed. Second in this diagram is skill. Teaching what? Learning and rehearsing new skills. I'll oftentimes work with people who have done really great work helping a young person get ready to make change and want to make change, and sitting with a young person who says, I'm going to do it. And then the weekend rolls around and they didn't do it, and I might even hear a counselor who uses words like relapse or regression. And I'll always sit back and I'll think, did we teach them how to do something differently? In our field, we hear the term rehabilitation, or, I got to go to rehab, those kinds of comments. And rehabilitation, to me, rarely is that actually the work we're doing. Rehabilitation suggests that there was a good, well-functioning, healthy state, that there was an injury or an illness, that we have to go to physical therapy to repair that knee, get it back in working order. Primary rehabilitation says that we need to teach things to people that they may not have ever learned. We may need to teach coping skills that have never been applied. We may need to teach communication skills that have never been learned. We may need to teach stress reduction skills and decision-making, and how to manage your emotions and how to manage your behaviors. And we teach them, and we need to rehearse those skills, because just hearing about them and just talking about them doesn't allow us to apply them in real-life situations. The last frame in this model is capacity. And if motivation is why and skill is what, capacity is how. It's recognizing that people learn in different ways, and people think in different ways, and people understand in different ways. We're talking about developmental capacities and learning styles, but we're also talking about situational capacities. And what I mean by situational capacity is what happened last night, or what time of year is it, or how much daylight out is there, or did we have good nutrition? Did we eat breakfast this morning? Was our client awake all night last night because of the violence that was going on in her home? And we might be thinking that we're going to be learning particular skills or community skills today, but really what we need to do is help this young person take care of her nutrition needs and take care of her hygiene needs and maybe a little sleep. So we need to accommodate for not only developmental capacities or learning styles, but we need to accommodate for situational capacities. That's not relapse or regression. That's working with a person in their life space and helping them to improve that. So motivation, skill, and capacity, a dynamic. In any given day, these vary. One grows more than the other. One compensates for the other. But in our work, which includes teaching and counseling and parenting, when we're hitting on all cylinders, that's where we're seeing performance and positive outcomes. So when we think about the motivation, skill, capacity frame, this is going to be a foundation for some of the things that I'm going to offer a little bit later on. Before we move too far away from this one, I just want to offer a similar one that guides our roles. So motivation, skill, and capacity, I often say you can think about that when you think about everybody else. Everybody else. In this model, understanding, intention, and awareness, this is the one to think about when you're looking in the mirror. So this is what we think about when we think about ourselves and what we bring to our practice, to our teaching, to our parenting. Understanding is what do we think is going on. It's our hypothesis. I've listened, I've learned, I've looked, I've asked questions, I've talked, I've heard. I believe this is what's happening. Based on my understanding, there's things I do with intention. What do we think is going on, and what do we do about it? Sometimes I'll acknowledge that with understanding and intention, we can do no wrong. If we are acting without either one of these, we can do no right. If we're acting but we don't have an understanding of what's going on. We're just randomly throwing out strategies or ideas or acting inconsistently. If we have an understanding but we don't do anything about it, we're not going to see any change. So understanding and intention built on awareness, which is really about self-awareness, which is just to acknowledge that this stuff is hard. And it's easy to talk about, and then you're faced with it. And again, whether you're faced with it in the counseling office, in the school hallway, or in your child's bedroom at 11 o'clock on a Friday night, we have to think about what are we triggered by, how are we taking care of ourselves, how are we self-regulating so that we can be the best counselors, educators, or parents for the children. When we are doing this well, that's when we're providing effective interventions and supports for students with co-occurring disorders. So I just want to make a quick comment, not too much of an editorial comment, but a quick comment around some of the emerging trends in the practices that we're seeing these days, and particularly around some of the evidence-based practices. There is a lot of science developing very well around treatment and support for young people and transition-age young people who struggle with co-occurring substance abuse and mental health issues. But I just want to always remind us that the science is built upon the art. And another way of saying that is the techniques and strategies and evidence-based practices always have to be built upon positive, healthy, empathic, hopeful relationships. That might be the counseling relationship, that might be the teacher-student mentorship relationship, and that is certainly the healthy family, parent, and child relationship. And if anyone pushes back on you and says it's not evidence-based practice, well, a brilliant clinician, psychiatrist, MD, and researcher by the name of Ken Minkoff, who's been in Vermont a fair bit, and his colleague Chris Klein have done the research, and in fact, as you'll see from the quote from their work, empathic, hopeful, integrated treatment relationships are one of the most important contributors to treatment success in any setting, and the provision of continuous integrated treatment relationships is an evidence-based practice. So we'll all just always hang on to that. Very briefly, to talk about what we do in treatment, or how we approach this work in an integrated and coordinated way. Good treatment services look at history, look at today, here and now, what are we going to do today, and have a future orientation. What are we working towards? So an integration of both the history, the present, and the future within specialized treatment, integrated treatment services. Wrapped in a comprehensive care model. Talk therapies, a 50-minute therapy hour, if that results in behavior change at the dinner table tonight, at school tomorrow, or on a Friday or Saturday night, great. But if it doesn't, we need to do more. And we can absolutely sit with young people who let us know their best intentions and don't follow through on those best intentions. And they're not lying to us. They're not trying to get over on us. It's just that talking intentions, talking about new skills, talking about making different choices, and then actually being able to put them into play when you're faced with their real-life situations are wholly different skill sets. So comprehensive care, cognitive behavioral therapies, group therapies are very great, very good at helping to translate these ideas into action. Within treatment services, we want to be focused on all 8 domains, issues of social, emotional, mental health, and substance abuse concern, cross all of these domains. When we can help young people really develop the assets, the connections, the skills, the supports, the motivation in these 8 domains, then we're going to see great outcomes. Needless to say, some young people are able to develop more assets in these domains than others. Some people walk in the door with more assets than others. Not everybody's going to hit in each category, but this becomes our lens of the work, recognizing that we see the greatest long-standing success when we can address issues in all of these areas. And then, when we're really talking about long-standing success, we're talking about natural supports. We're talking about translating the skills and the abilities and the capacities that our young people develop beyond any formal setting, beyond treatment, beyond counseling, into their natural world. Natural supports that might be family or extended family, community connections and partnerships, mentorships, establishing themselves independently of formal treatment services. So this becomes a focus of work within a good integrated treatment model or a good integrated treatment program. Again, one more point on this. For those who may be less familiar, Vermont does have a system of addiction and integrated treatment providers comparable to the designated agency system for community mental health. You'll see from this map that in a number of counties or a number of areas, the designated mental health agency is also the designated substance abuse agency, United Counseling Services in Bennington or Counseling Services of Addison County. In some areas like Chittenden County, you'll see there's a lot of services here in Chittenden County. The designated mental health agency is a substance abuse provider, and there are others as well. And then in some counties, Washington County as an example, there are two designated substance abuse treatment organizations, integrated treatment organizations, distinct from the mental health agency at Washington County Mental Health. So a range of supports and resources for folks statewide. I've got my eye on the clock, so I'm going to move a little faster here, and I'm going to skip through this slide, but just to acknowledge that integrated treatment addresses underlying issues, teaches new skills, rehearses these skills, and considers contextual and environmental factors with consistency, intensity, and duration to reinforce engagement and provide sufficient support. Just because there's a good moment for a breath here, I think folks might be familiar with the Serenity Prayer. Certainly it finds its way into lots of places, and recovery communities embrace this. And I do a little edit to it when I think about adolescent treatment, which is just the same as adolescent parenting in some ways, which is granting me the serenity to set limits when they're necessary, to be tolerant when they're not, and the wisdom to know the difference. And if I can do this on a good day, then we're doing good work at Centerpoint. But jumping into what do we do? If we ask why, if we ask how, if we ask what it means, if we have frames of understanding, what are the things that we're going to do? And this is where I'll offer some core strategies that can apply in any setting, regardless of your role. In fact, at Centerpoint, we'll acknowledge that the core strategies that I'm about to offer are important for our school social workers. Our teachers apply and use them. Our special educators consider these. Our substance abuse and mental health clinicians consider these. My office manager practices with these intention, as well as do I. And the first that I'll say is that we need to carry ourselves with personal presence that is dynamic, engaging, responsive, and participatory. Frankly, we got to bring it. If we are expecting something of our students or of our young people, we're expecting engagement, we're expecting enthusiasm, we're expecting participation, we're expecting presence, we're expecting health, we've got to do the same thing. We've got to demonstrate it. And I think every parent listening can probably think about the first time their child, perhaps even a young child, reflected back to them their own behavior. And it became a reminder that, oh, maybe I swear too much. Or, oh, I didn't even realize I was saying that out loud. Or, oh, I'm just having a beer with dinner, but my son's talking about beer now. So we have to carry ourselves as models, and we have to carry ourselves demonstrating that which we expect from our young people. Again, expensive words here, but paradoxical interventions to enhance cognitive dissonance. And I'll let people read the screen for a moment. And what I'll acknowledge is that for many of the people we work with, many of the young people we work with, they believe they know what we're going to say before we say it. And if we're not careful, they're going to be right, because we all fall into scripts. They do something or say something, we respond or in an expected way, which reinforces the cycles that currently exist. And really what this is saying is that we just need to do it differently. We need to get off script. In fact, sometimes when we use the things that get off script, that create the cognitive dissonance, we'll have somebody scrunch up their face and say, huh? What are you talking about? And again, sometimes it's a little less polite than that. But when somebody says to me, what are you talking about? That's a question that gives me permission to answer it. Because when I'm talking at young people and they actually haven't asked questions, they haven't given me permission to talk to them about the topic, I feel like one of those Peanuts parents just talking and all the noise is going over their heads. But if we can get them to say, what are you talking about? I don't understand. What do you mean? Even if sometimes that question is shared with a little bit of an adolescent attitude, that gives us permission to talk with them, to answer those questions, and maybe to create some different thinking processes. Differentiating between the student's goals, aspirations, and others' expectations or hopes. Again, an eye on the clock, I won't read this slide, but I'll just acknowledge that I often will sit in team meetings or IEP meetings, and I'll hear conversations around the student not demonstrating progress on goals, and I'll think to myself, we're not talking about the student's goals. We might be talking about the parents' goals, we might be talking about the school's goals, but the school's goals might be for a student to attend school regularly, and a parent's goals or hopes might be for the student to be successful and happy, and the student's goals might be to get people off their back. And the truth of the matter is, all of those goals are important. They're just not the same thing. Students' goals and others' expectations are not the same thing. So we need to differentiate between those and work on all of them, but make that differentiation so that we don't get stuck in pursuing the wrong goal. And through that, we identify the change in target behaviors as a strategy rather than a goal or an expectation. Interestingly, I've got a colleague at Centerpoint who's worked with me for 17 years now, an incredible counselor, great addictions counselor, and even 17 years later he'll say how funny it is that rarely does a young person walk into his office with a drug problem. People walk into his office with mom problems and cop problems and school problems, and if everyone would just get off my back, everything would be fine problems. He can work with that. Now, of course, we know that one of the ways to address mom problems or cop problems or school problems or get off my back problems is to stop getting high. And the stopping getting high or decreasing substance use becomes a strategy rather than a goal. So all this slide is saying is we don't need to get lost in a person saying, I will or I won't, as long as we're focusing on whether they do or whether they don't. We'll work with 15-year-olds who say, I'll stop getting high now, but I want to let you know as soon as I'm 18 or as soon as I'm 21. We don't have to get stuck on that. Truth be told is if a young person stops getting high at 15 and they go 3 years without getting high and they do smoke again at age 18, what has been able to be achieved in their performance and their behavior and their brain development in those 3 years is remarkably improved as compared to what would have been achieved if they had been high the whole time. And we also know that the longer you're off, the longer you're likely to stay off, and that's a good thing as well. Unconditional positive regard for the individual with conditional response to the behavior. I frequently run into situations where people are operating with only half of this equation. Unconditional positive regard is our acknowledgement that the people we are working with are wonderful, valuable human beings regardless of their choices, and they make choices to which we need to respond. And good choices are rewarded and poor choices are sanctioned, but we make that distinction. I see lots of people who show unconditional positive regard and hold no accountability or consequence, and I see lots of people who hold consequence but outside of any relationship or outside of any relational affiliation, and it falls short. We know that sanction avoidance in and of itself is not a motivator for change or reward acquisition, doing a thing to not get in trouble or doing a thing to get rewarded in and of themselves don't result in long-term change. If anyone has a question around that sanction avoidance, just go down to our prison systems are filled. But the primary motivator for change is relational affiliation and relational attachment. And with that, we show unconditional regard for the individual, and it works out pretty well. A quick comment on this would just to acknowledge I have no problem with people feeling guilty. People make poor choices. I want them to feel guilty about them. Guilt is about what people do. I have a big problem with people feeling shame because for a lot of people, shame is not about what they do, but about who they are. Many understand if they do bad, they are bad. And we really want to use this core strategy to help break down the difference between do and are, or the difference between shame and guilt. Emotionally divest from knowing the truth. Again, I'll have an eye on the clock, so I know our time is running short. All I'll say to this is that let us not be detectives. We want to hear, we want to learn, we want to listen, but our work is not to prove that people are telling us the truth or to prove that people are lying to us. We should assume that what we are hearing is some version of the truth or their version of the truth or their experience. What happened at a party on Friday night, I'll never know unless I was there, and I hope I'm never there. So we hear what people share with us, we explore, we help them find the themes, trends, or the implications of their choices or their behaviors, but we're not trying to be detectives or courtrooms with what they're sharing with us. Approaching the work with curiosity. We should be asking questions more often than giving answers. We're obviously, again, in whatever role the listeners in this webinar are participating, you bring life experience and perspective to those that you're supporting, parenting, or working with. However, the nature of our questions invite people into participating in conversation with us, and they can give just as much information to those who are listening as can our answers. Certainly when we think about adolescent development, self-actualization or making change just for the good of change, internal motivation is limited. So we do have to build on the more behavioral approaches, or we do have to look at external reinforcers, again, sanctions or incentives to help compensate for the limited internal motivation. But just to acknowledge that our work is to help people develop that internalized locus of control, to help people develop a sense of self, a sense of responsibility in the community. But until that is there, we have to put some other things in place. I've mentioned it a few times now, but I'll read it here. The power of our work comes from the corrective emotional experience that develops when these elements are provided not by a program, but through personal relationship, and that relational attachment is the essential element necessary for long-lasting change. I've been doing this work, some version of this work, for about 25 years now. Sometimes intentionally, someone that I've worked with ages ago will find their way back into our front door. Sometimes in need, sometimes just to say hi. Sometimes I run into people unintentionally or in the community. And it's always nice when I run into somebody and they say thanks, and I just have to acknowledge that I've never, ever had a young person who's now an older person come back and say things to me like, I want to let you know that Act 264 plan was the best plan ever written, or that IPC was such a great plan of care, or that IEP really had the proper accommodations in place. It's not to dismiss those tools. Those are important tools. They're essential tools. But it's to acknowledge that what people remember, what they appreciate, and what they use those tools to build upon is positive, supportive, healthy relationship and attachment, whether that's the professional relationship of a counselor and a client, or whether that's the familial relationship of a parent and a child. And with that, we need to instill hope. And the truth of the matter is many of the people we see have lost, or in some cases have never had, the belief that things can change, improve, or progress. That might be based on their own experiences. It might be based on what they're told overtly or subtly in their life space. But what we need to do is bring hope, and sometimes carrying the hope for them until they can carry it for themselves. And without hope, we cannot expect motivation for change to develop. I acknowledge that I have no problem with guilt, but I have a attention to shame. And similarly, sad is hard, but hopelessness is concerning. Excuse me. Okay, so when we think about instilling hope within a relationship that has good and healthy affiliation, and above that, all of the strategies to engage young people who often may not want to engage with you, who often say, leave me alone, who often say, Could you drop me off 3 blocks from school because I don't want to talk to you? Who will often say, none of your business. All of these things that we can build that upon. How we engage with curiosity, how we strive for the student's goals rather than our own hopes or expectations, how we do things that are unexpected, how we do things that are off script, and how we carry ourselves in ways that we are hoping for the young people to carry themselves with us, even when they're not doing it first. So, thinking about these core strategies, sometimes people say, yeah, well, that's obvious. That's easier said than done. That's common sense. I'll just offer a few reminders. The obvious isn't always so. Something that I've come to really learn, which is that common sense is not that common. I want to acknowledge that if you think this is too simple, if, yeah, I can do, yeah, that sounds like a breeze, that sounds like it's easy, it's not. It's particularly complicated. You need practice, you need support, you need skill, you need reinforcement, you need encouragement to be able to carry through on these things. Motivation and skill and capacity is easy to say, but to put it into practice is hard. Operating from a place of understanding, intention, with good self-awareness, it's easy to say, but to put it into practice is really hard. So if you think this is too simple, it's not. And similarly, if you think it's too complicated, it's not. So these things, with a little practice, with a good orientation, with the prompts and reminders that you use for yourself to remember, don't get caught in the power struggle. I want to say this. In fact, maybe it's, I don't even want to say that. Maybe I'm just hearing my own father say that to me, so I'm going to now say that and pass it on down the line. I'm going to do something different. Small changes can have big impacts. If you think it's too complicated, it's not. And with just a few minutes left, and I just got a cue that we can run a little longer, so I will give it a few extra minutes. I'd like to open up the screen for examples and unanswered questions. Before we do that, I will also put up this slide, or as we're doing that, I will put up this slide. There's a number of questions that we're probably not going to get to today just because of the time. There are also some questions that may come up that you should know I may not respond to online, simply because they're conversations that are best attended to individually or personally, or in more of a counseling or context. And I do want to acknowledge anything that would get into things that are either too personal or violate a person's confidentiality. So I'll leave this slide up with my contact information, and please do feel free to talk more or learn more or hear any more about some of the things that we talked about today. But at this point, I will open it up for questions. Okay, and I see one. How can parents learn skills to better communicate with their young adults who may wish to shut them out? There's a million-dollar question, right? How do you talk to a person who doesn't want to talk with you? Now, the million-dollar question does have a million-dollar answer, except it's probably 1,000 different answers, and most of those answers are going to be rooted in the core strategy that I offered. And I'll share a quick example of a young person that I was working with, a client I was working with, who didn't want to engage in the work. But boy, his girlfriend certainly wanted things to change in that relationship. So one day his girlfriend came in with him to a counseling session. She typically waited in the room. He said, you know, I'm not doing it, no effing way. We can sit here, but I'm not going to say anything. And I said, okay. And I went out and I got the girlfriend, and I brought her in, and I started a conversation with her. He stormed out of the room, then he stormed back into the room, then he stormed out of the room, then he stormed back into the room. And the fact of the matter is, he couldn't tolerate being in the conversation, and he couldn't tolerate not being a part of a conversation that I was having with his girlfriend. And so it was a technique, it was a strategy, it was off script, it was paradoxical, it got him in the room. There are many, many skills, and again, frankly, a whole other hour could focus on this very question. But I think about those core strategies that we offered, questions and curiosity and carrying ourselves in a particular way and showing it rather than saying it, and being present even when we're being pushed away, and doing things that results in a young person not being able to, no is not an answer, not being able to not engage, because we create the momentum for them to need to engage, even if it's you're talking to their friends or you're talking to their girlfriend. Let's see, there's a question up here. I completely agree that in the end it is all about relationships. That is what my daughter remembers over and above all the plans and all the interventions, the people who really cared and kept on caring, and there's an appreciation. And I'm glad to hear that feedback and wholeheartedly agree. Again, all of the practices and strategies and styles, and we use a lot of them at Centerpoint. This is not just good intentions. There is a lot of strategic intervention to our practice, but a hammer doesn't build a house, a carpenter builds a house. And skills and strategies don't improve relationships or build health. Relationships do that. So we use these skills and these strategies on top of good relationships. Are there support groups for parents anywhere? There are support groups in different versions around the state, different models. It is interesting that parent groups are sometimes a thing that is absolutely necessary, and sometimes it's a thing that is the hardest for parents to take advantage of when there are responsibilities at home and responsibilities during the day and meals and other kids. So if you're in, depending on what part of Vermont you may be in, I'm going to encourage you to be in touch with the local substance abuse designated agency or mental health designated agency. The slide that I showed up earlier, and I understand that those slides will be available for folks as a PDF. I will say more locally, at Centerpoint we have 2 parent support groups, a group that runs on Wednesday nights from currently it's 5:30 to 7, although it's a group that continues to run long, and so the time is probably going to change to either 5 to 7 or 5:30 to 7:30, because that group always has people meeting past the time that we intended and then continuing that meeting out in the parking lot. That's Wednesdays at 5:30 at Centerpoint, South Burlington. And then we also have started a group, Centerpoint runs a parent support group at the Community Health Center of Burlington on Riverside Ave, Mondays, and I believe that's 12:30. I would also just acknowledge that there's a new model starting in the Burlington, within Burlington City, particularly designed for parents of middle school students. It's a project called You Parent, a collaboration of the Burlington Partnership for a Healthy Community and Centerpoint. It's an interesting model because it is work and parent support group designed to learn the skills and to practice and talking about how to parent high schoolers, but we're actually working with parents of middle schoolers. And the idea is learn these skills, practice this, get comfortable, get connected, build a support group while your kids are still a little bit younger, so that you actually get these kids before they step into the deeper waters of high school, learn how to parent a 16-year-old before they're 16, learn the skills of parenting an 18-year-old before they're 18. I've even come to refer to this as what to expect when you're expecting a teenager. So that's a You Parent project. You can look at the Burlington Partnership website. The parent support groups are listed on our Centerpoint website. But if you're from a different part of the state outside of the Chittenden County area, I would encourage you to get in touch with your local designated mental health or substance abuse treatment agency. Again, just a few minutes, and there's a few more questions here, some of which would be longer to answer than in the time we have. But let me take a quick look. What age persons are served at Centerpoint? Centerpoint's full title is Centerpoint Adolescent Treatment Services. I think we need to change that name. We are now at Centerpoint seeing 8 and 9 and 10 and 11-year-olds through some of the work that we're doing in public schools, or even through the work that we're doing connected to truancy court. So that's certainly younger than adolescent, the latency ages. For many years now, we have moved into the transition age young people, 18, 19, 20, 21, 22, and as I mentioned earlier, we are seeing a real uptake in the college-age population that we're working with. So that's been, we've developed some specialized services for that transition age population. And then interestingly, as we've been at it for so long now, we're seeing young people who are coming back, walking in our door at age 25 and 26 and 27. Now, Centerpoint is not primarily an adult mental health agency. We're specifically not. In fact, the mental health and substance abuse services at the Howard Center in Chittenden County are really designed for the adult population. But we're seeing, you know, older young adults, 25, 26, 27, that we served 5 or 8 or 10 years ago, who at the time may have said that they knew everything and we didn't know anything, and then had a little life experience and might walk back in our door and say, hey, do you remember me? To which some of us most certainly do. And we say, come on in, because it is about access and it is about immediacy. And if somebody is walking into our door saying, I'm here and I need some help, we're going to make sure that they get that help, as opposed to giving them the city bus map and a couple phone numbers. We want to make sure that people are getting the help they need when they're looking for it and when they need it. So the long answer to that short question is that through Centerpoint, we serve people as young as 7 or 8, as old as 27 or 28, and we serve families. So we serve 38 and 48 and 58 and 68 as well, when we have parents or kin who are providing the primary support for their young person. And that's it for our time. So just before I wrap up, I'll say again, the slide that has my contact information, please do feel free to be in touch via email or my direct phone line with any additional information or questions. And I'd like to thank you for joining us today. This webinar will be archived on Vermont Family Network's website, along with all of the webinars that were previously recorded, and I've certainly seen some of them, and they've been great. Please do be sure to visit VFN's website at www.vermontfamilynetwork, all one word, vermontfamilynetwork.org, for a complete list of upcoming webinars, workshops, and support groups. And again, I'll thank you for joining us and wish you a very good day.